morning, good evening. Welcome to this webinar where we're discussing COVID-19, the burden, and particularly at-risk groups. With me, Professor Charles Feldman, who's an Emeritus Professor in the Department of Internal Medicine at the University of Witwatersrand, South Africa, and Professor Gabriela Scintee, who is the Deputy General Director at the National Institute of Health Services and Management in Bucharest, Romania. I'm very, very pleased to have them joining us here in this webinar, which I think you will find really enlightening. We particularly appreciate the support from the University of Geneva, from the World Federation of Public Health Associations, and from Pfizer. I will point out that the views expressed here are the views of the speakers and do not reflect any contribution or influence from our sponsor. The speakers are presenting on a voluntary basis and have not received any remuneration at all from the World Federation of Public Health Associations, and we really appreciate that their contribution. As I introduce each of the speakers, I'll give you a little bit more detail prior to their presentation. And first at the presentation is Silvia Gabriela Scintee, who has a master's degree in health services management from the London School of Hygiene and Tropical Medicine, a PhD in public health from the University of Medicine and Pharmacy in Bucharest. Dr. Scintee has extensive knowledge of the Romanian health system, has served in a wide range of roles there. She has also working experience at international level, and for over 30 years she has been teaching across the European and international areas and scientific networks on public health and health policy development. It's my great pleasure to introduce Dr. Silvia Gabriela Scintee. Gabriela, to you.
Thank you very much, Professor Moore and the World Federation of Public Health Associations for the invitation to this webinar and the opportunity to share the European experience. As infectious diseases do not know borders, I think it's of utmost importance to learn from one another. COVID-19 in Europe continues to be a significant public health concern. According to WHO COVID-19 dashboard, as you see, in the 28-day period from 5th of January to February 1st, 2026, there were 59 countries reporting cases across 3 WHO regions. There were 47,000 confirmed new cases. The third, you see here only 2 regions, because the third region is Western Pacific, where China reported 0 cases. As you can see, almost 30,000 cases, representing 63.7% from total cases, were reported by European region. But you should bear in mind that this is not an accurate situation due to the globally reduction in testing and reporting. Over the same 28 days period, there were equal numbers of hospitalized cases reported by Americas and Europe, with the difference that for ICU admissions, Europe reported 99 cases and Americas 130. As well, Americas reported almost 7.6 more deaths than European region. But where the Europe is not doing well is the vaccination, because here you see in December 2023, Europe had only 69% of the population vaccinated compared to 88 in Western Pacific, 81% in Americas, and 77% in Southeast Asia. Regarding the vulnerability factors, I'll not go through all of them, but I want to point that vulnerability is reinforced by the additive effect of multiple factors. For example, it's more likely for someone from a certain ethnic group to have poor education, low income, to live in an overcrowded area, and to have an unsupervised health care condition. As well, health system contributes a lot by poor vaccination rate, by poor testing and monitoring of infected cases, inadequate treatment for the diseases that constitute vulnerability for the infection with the COVID. Particularly vulnerable are still the populations in the regions with violent conflicts and wars. Unfortunately, more and more such regions lately. With disrupted healthcare services and displaced populations living in overcrowded areas and with no access to healthcare services. There were several studies in Europe on the vulnerability factors, and I can show you here on the left side the results of a bivariate analysis that took into account the proportion of elderly in the population and the rate of years of life with disability for COVID vulnerable health conditions. And the results in this analysis were that the most high-risk countries were Bulgaria and Portugal, followed by Latvia, Lithuania, Greece, Germany, Estonia, and Sweden. Another study, where you have results on the right side of the slide, calculated an epidemiological risk index for 2019, which is a composite indicators that took in account more dimensions and included indicators referring such as pollutant emissions, maritime or air transport, tourism, hospital beds, or health or social care personnel in relation to the population, or population at risk of poverty. According with this study, the spatial distribution of this index indicates that higher risks levels for the population in Europe are in southern and eastern regions. If we keep this in mind and we look to the excess mortality in 2020 related to the previous 5 years before pandemics, We might acknowledge that epidemiological risk index provided pretty good insights into the role played by socioeconomic, environmental, and health characteristics in explaining excess mortality associated with COVID-19 during 2020 in for the 252 European regions. Of course, additional research is necessary to fully understand the influence of different determinants, given the changing characteristics of different COVID-19 mortality waves since March 2020. The most important factor that changed a lot the population vulnerability and health outcomes is immunization. And now I will refer to another study on geographic disparities in excess mortality across Europe, analyzed in relation as well with socio-economic context, but also with different degrees of vaccine uptake. And if we compare Portugal with Bulgaria, which, if you remember, they were found to have the higher risk, they are equal in having the high percentage of elderly, high rate of vulnerable conditions for getting the COVID-19 infection, and the medium to high epidemiological risk index. But in what are they different? Is that while Portugal has very high vaccination rates, even more than the average in the European Union, the Bulgaria has a very low vaccination rate. In the same time, as you see from the right side of the slide, while Portugal has a low excess mortality, Bulgaria has a very high excess mortality, especially in 2021. So the vaccination, we think it makes a big difference in excess mortality rates of those countries. Besides the high cost in human lives, COVID-19 pandemics was a substantial economic burden for the society. A lot of money have been spent on health systems for treating a tremendously higher number of patients, for new investments such as ICU beds, ventilators, for hiring new additional health personnel, for finding e-solutions. But out of health systems, the countries also paid financial compensation for medical leaves or for those who were not able to make an income due to general lockdown, or provided essential goods to the individuals in quarantines. The pandemic had also a great negative financial impact on several industries, such as transport, tourism, and also produced disruptions on global markets. And I have here also several figures to show you, respectively from the 2023 WHO report on global spending on health. We can show that countries overspend per capita in average 11 to 12% comparing with the previous pre-pandemic years in high and middle income countries, and 5% more in low income countries. And the global spending on health, it was 9.8 trillion, which is much higher than the value before the pandemics, which, for example, in 2019, it was 8.5 trillion US dollars, and in 2017, 7.5 trillion dollars. As well, regarding the other costs, I like to present you the results of a study of John Appleby on the public finance cost of COVID-19 in UK, where it very clearly shows that out of almost 260 billion pounds as total cost, less than a quarter was spent on healthcare, 21.3%. The rest, and the most money were spent on helping businesses to run. But as Appleby mentioned in his article, not spending this money would have had greater cost in people's lives and in the general economy of Great Britain and United Kingdom. Sorry. At European level, European countries' responses to COVID-19 pandemics were closely monitored by the European Observatory on Health Systems and Policies, with the purpose of cross-country comparisons and analysis based on which to advise countries for better protection strategies and more resilient, building more resilient health systems. They also developed a methodology for testing health system resilience to different shocks based on analysis of each core health system function and its sub-functions in each of the stage of a shock, from preparedness and onset to the recovery and learning. Such assessment reveals the vulnerability of health systems and measure its capacity to absorb the shock and to resume its optimal performance as quickly as possible, and identifies the necessary measures to reduce its vulnerability to similar shocks in the future. An extensive analysis was performed by the observatory based on the data collected by the COVID-19 Health System Response Monitor. And these are several few, among others, important lessons that I want to share with you. Even the highly performant health systems were not sufficiently prepared to face the pandemic, resulting in the need to further strengthen their system resilience. Governance is the key to a resilient response, because even countries with high resources, if they don't have strong governance, they will not reach the desired health outcomes. Many years of underinvestment in some countries in the health system have had consequences. So preparedness plans should be always backed up by necessary resources and procedures to spend the money in an efficient way. Resources also include health workers. Health systems should have the mechanism in place to attract and retain high quality staff. As well, I would include among the resources category the social aids required by people in disadvantaged communities to reduce the inequalities in risk infection and severe illness and deaths. Flexible health systems are necessary not only in the view of reorganizing services, because in time of crisis you need to keep separately patients with the infection, but also in developing new models of care. As we saw, the other health services were disturbed. There is need for new models, including the adoption of modern digital technologies. Intersectorial work is very important as a crisis preparedness plan should follow and foster a One Health strategy due to the deep connection between human, animal, and ecosystem health. And not the last, building collaboration across different sectors is also required to find the mitigation strategy for the social factors that keep certain groups at risk, as many factors that pose the population at risk are outside the health sector, for addressing inequalities and protecting the poorest in societies. And in conclusion, vaccination and increased health system resilience are the best ways to save lives, to avoid overcrowded health systems, to save money, and not only for the health system, but also for the entire society, to preventing other societal costs and loss of productivity. Thank you very much.
Thank you, Gabriela. That was very insightful, and I particularly liked the comparison you made between Portugal and Bulgaria, both vulnerable societies, but the one that was much more effective in terms of vaccination has done. Portugal did so much better in the pandemic. But then to go on, after looking at vulnerability, inequity, vaccination, to look at the broader issues of financial burden and then come through there with the importance of resilient systems. Thank you very much, and we may well come back to some questions to you, but it's now my pleasure to introduce properly Charles Feldman. Professor Feldman is an Emeritus Professor in the Department of Internal Medicine at the University of Witwatersrand. He's also a non-clinical honorary consultant at Monash Health in Melbourne, Australia. His career as a pulmonology and intensive care specialist was greatly influenced in 1982 when he was a registrar at WFPHA and in training at the then Hillbrow Hospital. He witnessed at that time young patients with community-acquired pneumonia and saw how they succumbed to their infections within the first 24 or 48 hours. He's since made a significant international contribution and has international standing as a researcher, as a publisher in the fields of pulmonology, ICU, which have seen his involvement in innumerable international initiatives. It's my pleasure to introduce Charles Feldman.
Thank you very much, Michael, and thank you for the kind introduction. I'd also like to thank the sponsors and particularly the World Federation of Public Health Associations for inviting me to present in this symposium. My topic I've called the ongoing impact of COVID-19 because, as you've already heard, it still remains and has an important impact throughout the world to varying extents. I'm, as you may have gathered now, based in Melbourne in Australia, and I'm going to show a lot of the data that there's been more recently regarding COVID-19 in Australia. So I'd like to add that these the views that I'm going to talk about express my views and have nothing, no contribution or influence from the sponsors. So we know that public health action is needed to mitigate the impact of preventable respiratory pathogens. Here, for example, comes from the European Centre of Disease Prevention. You've seen similar sort of data, and you could see for weeks during 2023 and 24. And what you can see is 3 viruses here: influenza in blue, RSV in purple, and SARS-CoV-2, the cause of COVID-19 infection. And you could see during various periods of the year, different seasons, you get an interplay of these different viruses, which increase, decrease, and so on during that time period. But they remain in the environment, circulating in the environment at particular times during the season. So if you look at surveillance for severe acute respiratory infection in patients admitted to ICU, I thought I'd show the ICU cases rather than the community or patients out of the ICU, because obviously ICU settings still an important number. You could see the number of intensive care unit admissions. And what this really shows is a whole range of viruses. And what I'd point out to you is that at the bottom in black is the circulating SARS-CoV-2 virus going up and down in different areas. You also have influenza, as you see, as an important pathogen, RSV in green as an important pathogen. And in fact, in the last year or so, influenza in Australia has been particularly bad, with a particular virulent strain that's occurred, but it still has the background of SARS-CoV-2 circulation, and this is data from 2025. Now, if you look at who is getting these infections, these severe acute respiratory infections, it includes, as you've already heard, vulnerable people, but the ages are the young, the very young, as you can see, or the older individuals, and particularly the elderly. And the aging of populations is very important, as many of the older people, the elderly people by definition, are having high rates of infection, probably associated in many cases with comorbidity or even without comorbidity. And if you look at causes of death, and this is Australia between 2023 and 25, you can see in sort of red is 2023, light blue 24, dark blue 2025 from January to kind of November, middle of December. You can see that over the season, looking into the winter season, there certainly are a large number of deaths from COVID, although it has decreased after its peak in 2024. It has decreased in 2025. But I'd like to put the perspectives of death of COVID infection against those of other pathogens. So this comes from Australia as well. And really what I want you to look at are the 3 charts: death due to COVID on the top, in the middle due to influenza, at the bottom due to RSV. But importantly, pay attention to the units on the side. So if you compare deaths from COVID, look at the number of deaths from influenza. The units are much smaller for influenza. So you If you take the middle one of June, light blue, look at 682 deaths. Go down to June for influenza, 97 deaths. Go down for RSV, and once again, the units are less. You could see that the mortality is lower. So COVID-19 still remains a leading cause of death, acute respiratory tract death, certainly in Australia. And like many other countries, and these are these almost like heat maps, but they map out the different lineages or strains or variants of COVID that there have been. And you can see there's a great shift over relatively short periods of time, from January 2025 all the way into the beginning of January 2026. And you can see the variants have changed. What the previous speaker mentioned is that we're not necessarily routinely testing for the pathogens anymore. And so the numbers are almost certainly underestimated. But these patterning of the variants and lineages is very, very important, because it determines which of the vaccines should be used in that season that's progressing in Australia or any other country to match the lineages that are circulating. Age is a very important factor as a risk factor. And this alone is an important risk factor for all kinds of infection, including COVID. There are immunological changes that occur when one ages, and it's not just the elderly who get immunosenescence, which is aging of the immune system as one gets older. These changes start occurring from around the age of 50. So on the left and in the blue triangle, you have an individual who's got an active immune system with a lot of naive lymphocytes waiting to respond to the infection, with a good diversity of repertoire, effector cell functionality and proliferation. But all of these things change as a result of immunosenescence. And it therefore increases susceptibility to infectious diseases. Now, it's not only that's important, is the susceptibility to infectious diseases. It's also a consideration that needs to be given where the post-vaccination antibody titers may not be as high, and that needs to be taken into consideration in older people when assessing the efficacy of vaccines. So the elderly have reduced innate and adaptive immune function. It impairs the local response at the site of vaccines. There's a primary reduction in primary immune responses, reduced efficiency of B cells, T cells, antibodies, and phagocytic function of cells. But of course, vaccination is an important strategy to prevent infections. And this necessitates us studying the benefit of vaccines in the different age groups, and particularly in the elderly. So patients at high risk of infection, hospitalization, and severe disease, including these being important in Australia, are the elderly, those with certain health conditions, and you've heard many of these, and pregnant women. Immunocompromise is very important. It's not really just those who have cancers and transplants and HIV in countries such as in sub-Saharan Africa. Individuals using high-dose corticosteroids for therapy, or individuals with congenital heart disease or cerebral palsy or Down syndrome, for example, are also at risk, much like at the rate that immunocompromised individuals are. So high-risk settings are also important to consider. Obviously, these individuals in high-risk settings live in close quarters, but many of them have underlying medical conditions. So we're talking about aged care facilities or disability care facilities, hospitals and other healthcare settings, and certain population groups within communities. Many countries have certain populations that are at increased risk, and these include in Australia, Aboriginal and Torres Strait Islander people, people in aged care and disability care. Now, one of the things we need to know is that viral infections, of which SARS-CoV-2 is what we're talking about, but viral infections, starting with influenza, the story started, bacteria, and we've known this anecdotally for a while, that bacteria are responsible for the mortality in influenza, and the extent is much greater than we may have thought. And this is an old, I think it was the 1940s, poster in the UK, which says that pneumonia strikes like the man-eating shark led by its pilot fish, the common cold. And so we know, for example, in pneumococcal infection, which commonly has a synergistic interaction with influenza. So influenza destroys respiratory epithelium, upregulates molecules, and impacts on phagocytic cells. So there's bacterial increased adherence and increased susceptibility to pneumococcal infection. And many of the influenza pandemics that we've had over the years, starting with the Spanish flu at the end of the First World War, and going on to perhaps the swine flu, for example, in 2009, we had secondary infections. And the important issue that I'd like to bring out, and data has been shown from work in Australia, that you do get co-infections with SARS-CoV-2 virus as well. So these co-infections, and here in red, you see there are viral co-infections and the various things that happen as a consequence of viral infections. You can see in this sort of pinkish block. But you also get bacterial infections, and there are a whole host of different things where the bacterial infections influence viruses. What I haven't put in here was fungal infections, which is another big risk. And we know that these co-infections, and I'll show that to you in a little while, are very important for the mortality of COVID-19 infections. These co-infections cause more severe disease, there's tissue damage, and often you get a very exuberant inflammatory response with an acute respiratory distress syndrome, damage to the lungs, distribution through the blood, and mortality. I mean, what pathogens do you get that can occur with SARS-CoV-2? And you could see, starting with the pneumococcus again, but going through a whole host of other bacterial pathogens, viral pathogens, respiratory pathogens, very more important. Common pathogens remain common. And you can see, if you look at the factors related to severity, co-infection is associated with severity. Co-infection with a low lymphocyte count as a consequence, a very high risk for severe COVID-19 consequences. And if you add that dimers as well, all of these, co-infection is important. And if you look here, patients with secondary infections, if you look at non-survivors versus survivors, patients with COVID-19 who have co-infections or secondary infections, non-survivors have a much greater rate of secondary infection, as you can see, compared to survivors. And what another consequence, another downstream consequence, is that many patients with COVID-19, with or without secondary infection, in fact, receive antimicrobial agents. You could see here that the use of antimicrobial agents in non-survivors is extremely high. But even those that survive who may not have had secondary infections, use of antimicrobials, even if not needed, are very high. And studies report that the range of antimicrobial use can be as high as 100%. So vaccination would not only help reduce the burden of disease, but it would also reduce the burden of infections and therefore secondary infections, and decrease the need for the use of antibiotics, which would add to antimicrobial stewardship programs. Now, there are lots of complications of acute COVID in the blood, in the airway, in the lung, cardiovascular complications, sepsis, and so on. And these are often the immediate cause of death. Others include acute respiratory failure, certain groups with higher risk of death, ventilator-associated pneumonia, and massive vascular things such as massive pulmonary emboli. But what you also do, you also get long-term complications of COVID, sort of long COVID that we've talked about. You can't see the picture on the left. I put it in just to show you from a publication the absolute large number of potential complications, and on the long term, much easier to see the long-term, more common long-term complications, including the so-called brain fog, cardiovascular changes, respiratory changes on the other side, and endocrine and neurological changes that occur. And these, which have said to occur in up to 30% of populations, have long-term consequences, not only for the patients, but for the healthcare system. How are we doing with COVID vaccination in Australia? And in fact, I fear to say that we're not doing as well as we had in the beginning. I guess this is a fall off that many have seen. In the last 12 months, vaccine coverage in all groups was best in the elderly, but it also has been decreasing. And certainly in younger individuals, there is a difference. And clearly, we need to be doing much better than we are with vaccination. But this seems to be a universal problem that's occurred and is occurring since the COVID pandemic. So I'd like to finish off so we could have some time for questions by reminding you what we need for a successful vaccine program. You need government buy-in at the top there in blue, and you could see the reasons. They fund the provision, establish policies and delivery, and also assist with surveillance. You need healthcare professionals who understand vaccines, certainly see the benefit, recommend and provide vaccination. You need the public who understands the need for these vaccines, and accepts these vaccines. And in the center of all this, you need a media, not just television and newspapers, but also all the social media that people use, the X or Twitter, the Instagram, the YouTube videos, and so on, that produce and present scientifically valid and responsible information of vaccination and its benefits, so that all the stakeholders speak the same language as the patients would do, which is likely to improve patient uptake of vaccines. So thank you very much to the sponsors, and thank you very much for all of you for listening to me today.
Thanks very much, Charles. And between the two of you, that's quite a lot to process. The good news for people who are attending the webinar or their colleagues is that this webinar will be available to replay on the website of the World Federation of Public Health Associations after a few days. Professor Feldman, amazing. You've covered the overall seasonal rates, given us a good insight into a range of upper respiratory infections, looked at the most vulnerable, and I think for me, very interesting, the complications of co-infection that deal there. You've touched on antimicrobial resistance, and then concluded with a overview of what governments should do to have a successful vaccination program. And I think it's been really interesting for us. I'm going to remind those in the webinar, if they wish to put a question up in the Q&A or a comment, I'm happy to deal with that. But to start off with, you've both talked about vulnerable groups within communities and how we might deal with them. It seems to me that this puts a particular responsibility on healthcare professionals in terms of their own vaccination and recommending vaccination to others. Can I start with you, Gabriela, and then go to you, Charles? Should healthcare professionals take on particular responsibilities? Should governments push them? I'm hesitant to use the word mandate, but strongly encourage them to vaccinate and encourage others to vaccinate.
You refer to the health professionals. I have to tell you that I didn't stress this enough. It was not time in the in the presentation. But I want to tell you that in Europe, there is an European directive according to which if the assessments reveals that there is a risk of safety of health workers due to their exposure to biological agents for which effective vaccines exists, all workers, including students delivering health care during their trainee period, shall be offered free of charge vaccination. Of course, after informing them about the benefits and the side effects of vaccination and effects of non-vaccination. And for those who do not know, I have to tell you that European directives are usually transposed by the national legislation of European countries. It is not compulsory. I do not know how many countries transposed this directive. It is very important to protect health workers because, like in the airplane, if you don't protect yourself, you have no means to protect others. And we saw during the COVID-19 pandemics the problems created where health workers were affected by COVID and even have died. So it's definitely important to protect health workers. Governments should look at it, but like with the other categories, I'm afraid there are even in health field people that are hesitant to vaccination, and we have to work a lot to reduce this hesitancy to vaccination.
Charles, did you have anything to add to that, and particularly not only healthcare workers, but those and in aged care that look after others?
I think the first thing I'd like to say is that many surveys have shown that the most important reason that patients go and have a vaccination is a suggestion or a recommendation from a healthcare worker, whether it be a doctor, a nurse, a pharmacist, or a senior or valued member in their community. So the first thing is the recommendation. And I think in that case, it's important for healthcare workers to understand vaccines, to understand their benefit, to understand their benefits such that they go and take the vaccines themselves. One thing is to protect themselves. Yes, we understand that. That's a driver. But the other thing is to protect their patients. The ethics story goes that you need to think of the idea of a young, otherwise healthy healthcare worker who doesn't have the flu vaccine. So this is an ethics scenario. Doesn't have the flu vaccine, goes to work, doesn't feel well, but goes to work, a young, otherwise fit person, passes flu on to a person who's had a bone marrow transplant, and that patient of theirs dies of a nosocomial influenza infection. In many countries, and I think Gabriela mentioned this, the first people who got the vaccine against COVID were the healthcare workers.
Yeah.
In our country, that certainly happened. And I must tell you, I don't think there was a healthcare worker at my hospital who didn't flock to get the vaccine, which was for free as soon as it was available. That was protecting yourself because we had no idea what we were up against. But obviously, it protected the patients as well. And they say, as Gabriela says, what's the purpose of saving doctors first? Well, for every doctor you save, that person can go out and save many people's lives. And so that is what's called the multiplier effect. So absolutely, you need to go out and do it to protect yourself, but also ethically to protect your vulnerable patients, whether they're children, the elderly, whatever, comorbid conditions.
Yeah, yeah. Thanks very much. I'm going to go to a question put by Alison Colbert, and she pointed out that the COVID-19 response required rapid deployment of vaccines and therapeutics. What lessons do you see for regulatory agility and equitable access to health technologies for future pandemics? What are the lessons? Can I start with you, Charles, and then go to you, Gabriela?
Yeah, I think that we've learned a number of important things. First of all, we've learned how to handle a pandemic of an organism that we knew nothing about when it first occurred. And we learned that one can go ahead and use current platforms for vaccine development that have been around for multiple years, like the messenger RNA platforms. People say, how could we have developed these vaccines so rapidly? Well, we have the ability with PCR techniques to actually sequence the organism. Once we've got that, you put them in a messenger RNA on a messenger RNA platform, and you can rapidly develop vaccines. So I think we need to understand that this is ongoing technology, not something new that we've learned. And you just go and apply it to the new agent. And this could be applied to various different pathogens. And that's a very important lesson because it worked very well. But the population need to understand that and understand that this wasn't sidelining science. This was because the science was already there. And then the other thing is we need to understand that equitable distribution of vaccine throughout the world is essential in rich areas and in poor areas because many diseases migrate. I realize there were limitations on travel and all that, but only subsequently these diseases are globalized in a very rapid sequence. And we need to understand that preventing infections only in one area is not going to save the world. It needs to be equitable right throughout society.
In fact, Gabriela started her talk with commenting the virus has no borders. And with that in mind, Gabriela, did you have something to add to that response?
Well, what I want to add is also that not how to that we have the means to vaccinate population, but I think we as also Professor Feldman mentioned, we have to work a little more to reach the population in order to make them accept the vaccination. So we have to find the championships among people, because nowadays, earlier it was easier. You had only the health professional to advise you, but now you have the social media. So you have to also work on social media and to go with the information and to fight misinformation and to improve health literacy of the people in order to understand what information they get on social media and what kind of information to take as valid and what kind of information to take as false. So I think this is a very big fight we have to take in order to improve the vaccination uptake all over the places.
Yeah, and so as we educate our health professionals, we need to also educate our influencers.
Yes.
And they form a range of different groups. Um, I'd like to go to a question on Nepal specifically, but I think it has widespread ramifications. And I'm going to ask you both to give any final comment before I close the webinar. It's from Dr. Soro Parajuli. I hope I pronounce his name reasonably. What is your advice for follow-up COVID-19 vaccination in Nepal? Which vaccines best fit for the Nepalese population? And just before you start, I suppose I would like to say that when I think of COVID and COVID-19 vaccinations, I think of why we call them more COVID, because actually we have different viruses, the modified virus that we are actually vaccinating for, but we give it the overall name of COVID. But nevertheless, what should we be doing for the Nepalese population now? Can I go to you first, Charles?
I think the important thing, as I said, was to know what's circulating in your country. The World Health Organization and other organizations do allow participation for countries that don't necessarily have the complete means to do surveillance on their own. As I say, it's an important on a global aspect. And I think it's important to keep an eye on that because, as you saw with the data from Australia, it does change over time. I had my COVID vaccine at the beginning of the flu season last year, and the current vaccine for COVID in Australia has now changed. It's evolved, so to speak. So it's necessary to keep an eye out on what is going on in your country. That gives you the best idea on what vaccine then to develop or to import and then use. And I'm sure there must be data for Nepal, which I wouldn't have in my head. For those countries who really can't, go and do surveillance, I think in many cases there's not a vast variation in different countries of the world. The virus seems to go down a pathway of similar variations and variants occurring. And it would then be to kind of follow the recommendations of a big agency like the European CDC or something like the American CDC, for example, which would give a good idea of what would be likely to be circulating.
And that would apply also, Charles, to influenza?
Yes, it would very much apply to that. We normally, the Southern Hemisphere follows on the northern hemisphere. So the southern hemisphere knows what was circulating in the northern hemisphere. And that's based on what viruses, influenza viruses, are circulating at the time. You still get circulation of influenza viruses during summer, although the season is mainly in the winter. So you can predict, and it's, of course, the winter seasons in the northern hemisphere are different to where they are in the southern hemisphere. And sometimes the southern hemisphere vaccines have had to change because there has been a further drift of the vaccine serotypes contained in the vaccine, or the clades as they call them in viruses like that. And so it had to change. But in general, it really relates to what's been circulating just prior to making a decision on which vaccine to use.
Gabriela, would you like to add to Charles' comment?
Could not have more knowledge than Professor Feldman in this area, but as far as I know, indeed, the authorities and the World Health Organization and the CDC centers are advising every year according with the circulating variants. So it's and I cannot have knowledge about that specific area, Nepal.
Okay. But can you give us a final comment then for the webinar? Is there something you'd really like to, the biggest message you'd like to get across, and then to Charles?
It seems that nowadays we have plenty of evidence for better preparedness planning to avoid a similar crisis in the future. And on what concerns the health system governance function is critical. A country with strong governance is more likely to be able to respond effectively in a crisis and thus to limit the damage to health and to economy. And better preparedness, it's not a task for the future. As virus continue to circulate widely and the global vaccine uptake among high-risk group is declining, it raises concern on future evolution of this virus. So we should do this preparedness already now, as the threat posed by COVID-19 is far from over. And we should not underestimate this threat.
Thank you very much. Charles, final comment for you.
I'd like to just add on to what Gabriela has said, strengthening really what she said. One of the things that occurred during this pandemic was the enormous international collaboration. I saw this particularly as a deputy chair of our university's ethics committee, where ethics committees around the country, and included ethics committees internationally, got together to try and develop ground rules for how to handle these ethical questions that COVID brought out, because it was something new that none of us knew much about, like HIV in those days when it started. And I think that kind of collaborative work together should continue. It's extremely important because pandemics are global by definition, and we need to tackle them on a global level. But for a final take-home message, they say that you, the healthcare worker, you are your patient's best health advocate. To get vaccinated, so get yourself vaccinated to protect yourself and your patients, and advise your patients to get vaccinated for themselves, their families, and their contacts.
What a great way to conclude. So thank you very much, both of you. And thank you to our sponsors, the University of Geneva, Pfizer, and the World Federation of Public Health Associations. And a little reminder that this webinar will be available in YouTube and social media on the website of the World Federation, which is WFPHA. wfpha.org in a few days. Thank you so much for your contribution and for those who participated. Good night, good morning, have a good day, have a good sleep.
Yeah. Bye-bye.
Thank you. Bye bye.